and 𝐀𝐬𝐢𝐟 𝐈𝐪𝐛𝐚𝐥 surgeon. He has been trained in the iron and Indian. Currently, is working as a research consultant at PTI and studying monomer. He is very experienced in performing complex procedures. He is bariatric surgery, and I am especially dedicated about just in a very short notice, just in time 3 hours before, and dedicated for the iron to help us in this session. Thank you very much, Professor. And he's talking about the complications of the direct surgery, common sense, evidence-based prevention, and the direct management.
Hello, assalamu alaikum. Before I begin, I have to make a small confession. Hisham, our moderator and my long-term friend, called me yesterday while I was driving half asleep on Hisham, our friend and our moderator, he called me yesterday while I was half asleep driving to Dublin airport, and he told me, "Can you tell me a few lines about your intro?" And I said, "I will introduce myself properly if I'll make in time." So just 21 hours ago, I was operating on a post-robotic left colectomy leak done in a rural hospital in Ireland. The procedure was done in one of the Ivory Center in West. So now I am in front of a elite audience, the bariatric surgeon from the world and local in a 5-star hotel, and presenting something about the common sense about the complications. So complications don't care if you're working in Ireland, in a rural Ireland, or if you are in a 5-star hotel. So first we'll start with the why this talk. As we all know, bariatric surgery has become the mainstream surgery. Thanks to Food Panda in Pakistan, you can get your food in the middle of the night. And once it becomes mainstream, complications are inevitable. But morbidity is optional. Because we ignore physiology, we do shortcuts, and we don't have a system to fix it. So the only surgeon who claims he has no complication, either he is lying or he's retired. So bariatric patients are not a standard surgical patient. It's not just the excess weight. They have a hostile physiology. They have a lower physiological reserve, higher thrombotic and infection risk, and distorted anatomy. So even a small error in these cases have a big consequences. So we'll talk about the pre of wisdom before we go into the most important is psychology of the selection. So as we all know, as a surgeon, the lesser the indication, greater the complication. So we have to identify the red flag patients, the patient who feel demanding, entitled, who follow an influencer who has more Instagram follower than your FRCS degree, don't operate. Say no. WhatsApp University manufactures magic wands and patient has expectations on that. So tell them the reality. You cannot fix a disordered mind with a stapled stomach. And site clearance should not be just the rubber stent, it should be must before the surgery. There is another wisdom, and that's, so risk management begins with mother-in-law, not with the NCN. So like in our every Pakistani family, we have a socialite broker, a power broker, who wants to know everything and who is the patient advocate. So as I was trained in Ireland, one of boss told me, keep your friends close and potential litigant closer. Recruit them early. Give them a job. Ask them to monitor the patient urine output. They will be your advocate. At the same time, do not ignore the ugly looking daughter standing in the corner of the room. She would be your worst enemy. So, and the second picture, most of you guys in Pakistan remember this. So I created, with the help of the AI, arrogance fuels the mob. Humility, frequent communication is your best friend and best fire extinguisher. So classification, as my friends were talking about the classification, so I have a different say about the classification. If your classification is not able to guide you about the patient management, it is just academic. So either it's timing, It's about physiology, sepsis, hemorrhage, obstruction, or it's a decision base. You have to observe, you have to drain, you have to scope, or you have to reoperate. So one of my favorite surgical authors, Shine, I think he's my virtual teacher. So he had a philosophy about the bariatrics. So complications are rarely random. Mostly they are foreseeable, preventable, and worsened by hesitation. So trust physiology over imaging. Early actions beat elegant delay. Ego is the more dangerous than disease itself. Pre-operative prevention, common sense is still very common. Patient selection, as I previously told. Bariatric surgery is an elective procedure, so start saying not yet. Prepare your patients. Patients who have unrealistic expectations, who have a poor engagement for follow-up, who have untreated psychological disease, say no. Prepare them. Lesser the indication, greater the complication. I would say it again. Now we talk about the evidence because there are a lot of scientists here. So pre-op weight loss is very important. It reduces the liver size, makes your operation much easier. Correct iron, vitamin D, B12 and D deficiencies. Thromboprophylaxis is very important. Start at pre-op. GLP-1, as you know, it's the new thing and everybody is talking about it. So if your patient is on GLP-1, hold it for 14 days. If GLP-1 is on board, then reflux is in Rome. So number two, the liver of the stone. If your patient has the liver of the stone, the surgeon will sweat. So 2 weeks pre-op high protein diet is compulsory. So that will help shrink the liver and make your surgery much easy. Vitamin D deficiencies. It's very common in Pakistan. We are brown people making house in a Western style. We are not seeing the sun anymore. So if you see vitamin deficiency, treat it. Otherwise, this is the recipe for an asthmatic leak. A little bit about, there's a lot of surgical giants here, so I will have a few words about the technicalities. A long sleeve gastrectomy, long thin friend, but don't make a narrow enemy. Follow the rule of 6. Use bougie. Ask your anesthetic friend to move the bougie when firing the staplers. Sleeve is a reflux factory. So if you see a crura more than 2 centimeters, please repair it. Roux-en-Y, the gold standard. The gold standard is only gold standard if you close the gaps. Make appropriate limb length that should read without tension, and 2 extra minutes of seeing the corners will save you 2 months of misery post-op. One anastomosis, the favorite middle child. It's one joint is easier than 2, but bile is a harsh guest. It is usually, evidence says 33% of the patient will feel it. Make the limb length appropriate. Measure the total bowel length from IC valve, and it should be a tailored approach, not a copycat. So gastric band, I have never put a gastric band in, but I have removed good few, done in Belgium when I was trained in Ireland. So it's a 1990 solution for a 2026 problem. So the band, my boss used to say, the band is like a bad marriage. It starts with the hope and ends in a painful divorce. So Dr. Tahir Yunus is here. He's the main surgeon, and this is I call the new dance, SASSY and SASSY-S. SASSY, the metabolic habit for a diabetic patient. I will say SASSY is a metabolic fineness, versus SASSY-S is a malabsorptive force. So SASSY guides metabolism and SASSY taxes nutrition. So choose wisely. The second new dance, the SADS, it is a sledgehammer for super obese. So don't use sledgehammer to crack the nut. It's less than 35 BMI, don't even go there. Powerful tool has a powerful consequences. Select with humility. Endosleeve. I happen to be endoscopist as well as a lot of my friends know, but I don't do this procedure. It's a trick without a knife. but suture fails, stomach expand. And gadgetry is often a substitute for clear surgical thinking. I think I should take few extra minutes. I traveled all the way this morning. That's just about the eating habits, biryani factor. You cannot staple out a Lahori diet, where liquid diet means milkshake or malai wali lassi. And your patient is asking for nihari and biryani on day 4 of the surgery. Old line, calm in crisis. If you're 3 hours in revision and sweating, stop, call a senior. They might not have faster hand, but they have calmer eyes. There is no shame in calling for help. There's a shame in burying a patient because you were proud. Legal and financial common sense. We have a PhD in Pakistan, and then there's a lot of social media influencer we are getting these days. So 5 minutes of thinking beats 5 years of litigation. So communicate, write notes properly. In Pakistan, private sector waive the fee if complications occur. Money is the best fire extinguisher for angry families. Intraoperative complication, my colleagues have elaborative talking about bleeding. So sleeve, he already told a lot of about. So I would say only don't rush the last 10 minutes. Otherwise, your patient will spend next days in ICU. Staple like leak is a dreaded complication. It is a lot of reason. Average leak rate is 2%, but morbidity is 100%. Be careful. Leak detection is very important. Respect the heart rate and CRP. Don't look at your patient, not at the pixel. CT scan lies. Fever is a late sign and pain is the subjective. Leak management is very pragmatic, not heroic. If there is a stable patient, you have a lot of options. Unstable patient, when the ship is sinking, don't read the manual, plug the hole. And do not resuture a septic staple line. It's like trying to stitch the wet toilet paper. Bleeding mostly it settles itself, but most important principle is re-laparoscopy early beats the late laparotomy. Venous thromboembolysis. Sometimes the first sign of P may be the last. So be careful, guide the patient. Late complications are missed. So weight loss, the most important is the internal hernia. It is if your patient has unexplained abdominal pain after bypass, it's internal hernia until proven otherwise. Close your gaps, please. Marginal ulcers. So it's better to control your risk factor than to treat these things. Smoking, no. Non-steroidal anti-inflammatory, stop it. Ischemia and tension is a technical flaw. I think there's 3 minutes left, he told me. I'm just 3 slides. Okay? Okay, I will just go to the last slide then. Okay? This is the third world reality. Yes, this is very important. So in Pakistan, I would say don't buy a robot if you can't provide the clean towels. We re-sterilize single-use items. We operate on the robots while there is a load shedding. So be careful about that. Second victim, I was going to talk. The take-home message is very important. So it is about the commandments of bariatric surgery. Respect tachycardia, optimize before you operate, close all defects. Imaging never replaces judgment. Early intervention saves life, ego kills, and symptom beats heart. These are not rules. These are the scars turned into the lessons. Final thought, bariatric surgery is a powerful medicine. Power without judgment causes harm. These are the 4 more important people in my life. One is sitting here, Professor Farooq Afzal, who told me how to spell bariatrics. The other 3 guys, none of them were a bariatric surgeon. One was a GI surgeon who used to do sleeve for fun. The second one was a liver transplant surgeon who was who taught me how to do a roux-en-y gastric bypass. Third is the prominent weight loss surgeon, pioneer in Ireland, who started weight loss surgery in Ireland. Thank you very much.
Thank you very